right, so the question is what are your thoughts on using TPA in a cardiac arrest patient who appears on the surface to have quality of life? So they potentially, based on the limited history you have and the way that they appear, they could leave the hospital and have a quality life if you could get them back, is the question. So all jokes aside, I really think this is where ultrasound comes in. I really do. I think that if you've got a patient who's in cardiac arrest with a massive RV and a small, tiny hyperdynamic LV, treat it like a PE and go ahead and lyse them. We had a case, what was that, about a month or two ago with a clot in transit. We could see the clot bouncing back and forth between the RA and the RV. Well, it's obvious. We know what the diagnosis is. I don't need a CT, and I don't need loads of epi. I need to give this patient TPA. So it was a no-brainer, and we pushed TPA. And that patient did leave the hospital.
What about for suspected MI in arrest? Because like if they were, I had chest pain, called out for it was BFib. Yeah, that's pretty much MI until proven otherwise, but that's not necessarily going to have that blown RV or something.
So I would again take a look at the heart, make sure that the aortic root is not big and dilated, make sure there's not pericardial tamponade, and I would try to look for wall motion abnormality, understanding that we may not be able to see that. Understanding a lot of you won't be able to see that. But if you have that history in a patient who doesn't appear to have a dissection, who doesn't appear to have tamponade, yes, Alexa, why not? I think you should.
For me personally, I think I use a little bit less ultrasound to make this decision. If there's not tamponade and it's a young person and it was a witnessed arrest, I'm pushing TPA on most of these. If they were a good functioning person. Because most of the stuff that would cause that, a 45-year-old that's grocery shopping and suddenly, falls to the floor, a lot of that stuff that wouldn't already have been fixed by good, appropriate CPR and defibrillation and things like that would have gotten done before they even got to me is at least potentially fixable by TPA. So I'm in the ironic position of I love TPA for essentially every indication except for ischemic stroke. Because I push this a lot in arrests.